Okay, ladies and gentlemen, thank you very much. Intracranial aneurysm. The jump is to go to the extracranial venous pathology. The spinal cord associated this in the scientific way responded, as you may see, with a lot of editorial and commentary against this vision, but with a very strong group of people, vascular or neurovascular background, that are interested in working in this direction. And in fact, the evidence of the extracranial venous pathology is growing, because pathology is still the benchmark in medicine. It's not an opinion, it's not an editorial, it's not a commentary. And what we know now is that any lower of the CCSVI jugular wall exhibits abnormalities with respect to control tissue. So it's a vascular pathology. In the intimal lower, we have loss of endothelial cells. In the medial lower, there is an excess of type 3 collagen with an inverted ratio between type 1 and type 3 collagen. And in the adventitial layer, we have calcification. Calcification exactly having atherosclerosis. This beautiful electronic microscopy shows in control vein in the top panel, you may see a very regular disposition of the endothelial cells as compared to the bottom panel, where you can see the irregular surface of the endothelial cells in CSVI condition with crater and disruption in many points. Looking at the jugular valve, a jugular valve in this condition are frequently not mobile, are stuck valves, and sometimes are inverted. Look at this picture. I don't know if this does not work. However, the pocket of the valve in the second figure, the pocket of the valve is inverted because it's directed against the flow coming from the brain, and this may cause really obstruction or restricted venous outflow and a big delay in the venous circulation. Look at the bottom panel. This is the magnification of the stuck valves, and the stuck valves does not exhibits any endothelial cells at any magnification. So it seems like a fibrous tissue, something really different from control tissue. Ultimately, this is a Nature scientific reports, a group coming from 3 different countries, Australia, Italy, and France, demonstrated the presence of hypercalcification in the adventitial layer of a jugular vein in CCSVI condition. Intraluminal obstacles, defective valves, but also compression is a further cause of CCSVI and often is associated with intraluminal defects. One of the most characteristic cause of compression is the omoioid muscle. You may see in the figure at the bottom of this slide that there is no intermediate tendon in the two bells of the omoioid muscle, and this creates an entrapment of the jugular vein. This can be really very well imagined either by ultrasound or by MRV, and this is called the pencil tip sign. There are many critical points because pathology is very clear, but it's not mirrored by standard imaging methodology to identify CCSVI. Doppler ultrasound studies show a big variability. So from 0 to 100% in more than 24 epidemiological studies performed by using Doppler ultrasound, there is a big variability. There are 3 meta-analyses showing the prevalence of CCSVI in MS, but maybe due to this variability, this is certainly one of the critical points that now we have to front. MRV is very accurate for wall stenosis, for compression, but it's not capable, unfortunately, to image the intraluminal defects. The majority of interventional reports by the means of catheter venography clearly show a big prevalence of CCSVI in these patients, but there is a very important study published on the Lancet that I show in some minutes that challenge this vision. Finally, IVUS seems a gold standard, but unfortunately is invasive. This is the study which was published last January on the Lancet, and is a Canadian group, confirmed the elevated prevalence of venous narrowings in patients with multiple sclerosis, 74%, but in the same time, the author did not assess a significant difference with the control population. However, they used a criterion for assessing stenosis never used in literature and never quoted in the journal. They assessed a greater than 50% wall stenosis by comparing not the segment preceding the narrowing, but the entire jugular vein measuring the narrowest and the widest diameter. Clearly, the diameter in normal people, the jugular, on the right, the maximus is 2, and the minimum is 1. Exactly 50% stenosis. On the left is 1.8 and 0.4. So in normal population, it is normal if you should compare the narrowest with the widest point of the internal jugular vein, you find stenosis. This is the reason because the proposed methodology was completely unable to separate healthy controls from MS. This is an angiogram. In A, you see healthy subjects, and you see the jugular in the region called the bulb is certainly more than 50% greater respect to the segment at the level of the foramen or at the level of the outlet with the subclavian vein. So this is normal to have more than 50% stenosis. But if you look the CCSVI case, you see in the junction a septum that creates an obstruction of the vein without any reduction of the wall because it's an intraluminal obstacle. This creates a great delay in the activation of collateral circulation. To overcome this kind of problem on the jugular vascular and interventional radiology, this group proposed to standardize the flebogram in terms of volume of injection, time of injection, number of frame, and they found in normal cases less than 2 seconds to have the clearance of a contrast dye, more than 4 seconds in about 80% of people with MS, with a big proportion also of patients with more than 6 seconds. I think that, and I recommend to everybody who is interested in this field to use this kind of methodology, because this evaluation is certainly more reliable respect to calculation of the rate of stenosis. Also because, as I showed you, the majority of cases are obstruction due to compression or intraluminal obstacles, and not wall stenosis. Today, what in CSVI did the investigator really assess? One is what I show, the light clearance time of the jugulars, and this can be also done, as showed by Mancini and other, and Monti, by using bubble ultrasound. So contrast for ultrasound. You may inject in the arm, and you may calculate the time of clearance of the jugular vein. Increased collateralization. This was mainly due thanks to a two-dimensional MRI and also with quantification ultrasound. And practically in normal people, we have more than 85% of the inflow to the brain that is drained to the jugular and the vertebral veins. To the contrary, in CSVI condition, more than 50% of the inflow is drained by the collateral circulation. Increased brain outflow resistance, and also restricted brain venous outflow even in favor of gravity. Step by step, there are a lot of investigators that found that extracranial venous pathology is more and more associated to neurodegenerative disorders. No more the first model of multiple sclerosis, but Alzheimer's disease and brain aging. Quite recently, Parkinson. A lot of paper about Meniere and also sudden hearing loss. Normotensive hydrocephalus. So the question is, what are the unifying mechanisms that may concur to neurodegeneration in so different pictures? What we know is that CSVI impact the pathophysiology of the brain, especially in two aspects. The first one is impaired CSF flow dynamics. And the second one is brain hypoperfusion. Both aspects are very important part of the pathogenesis of neurodegeneration and are strongly influenced by the venous drainage. The production of the CSF flow at the level of the choroid plexus is not influenced and was not measured any difference respect to control people. But to the contrary, at the level of the reabsorption into the superior sagittal sinus from the subarachnoid space, there is certainly differences. And this is due to the physical phenomenon of a reduction of the gradient of pressure. Because if you should have both the jugular that are obstructed, you have a significant increase of the pressure in the sinuses. CSF reabsorption depends exclusively from a pressure gradient. To have reabsorption, you need of 5 millimeters of mercury of differences between the subarachnoid space and the dural sinuses. And the velocity of the reabsorption is 0.1 milliliter per minute, each millimeter of mercury of the gradient. Of course, if you should have increased pressure in the dural sinuses, the reabsorption is low. Normal CSF proceeds forward during heart systole and backward during diastole, as you may see. And we calculated that in MS and also in other disease, as I may see in a minute to you, there is a significant reduction of the fluid dynamics. But much more interesting for neurointerventional perspectives is if you should measure the CSF flow dynamics after PTA, this is a control study done in Buffalo, you may see that there are two groups of people. A group was treated and the other acted as a control group. And with the treated group, there is a significant increase in flow and in velocity of the CSF after ballooning the internal jugular vein and the avagos vein if CSSVI was demonstrated. This is a very interesting study because it's a pilot study. It's a pilot study that really is a lesson learned from the pathophysiology point of view, because demonstrate that the reduction in flow and velocity during neurodegenerative disease is linked also with the venous function. And this can be correct by intervention on the venous part of the circulation. Is stagnating CSF an important piece of the puzzle? There is an inverted relationship between lesion load at MRI in MS cases and CSF flow velocity. This was published 2 years ago in the Journal of Magnetic Resonance Imaging, but probably more and more interesting in clinically isolated syndrome that sometimes is the onset of MS, and about 50% of people do not proceed to episodes, clinical episodes. If you should have a reduced CSF flow, your probability to progress into clinically defined MS is significantly greater. And also, the same group published that slow CSF flow increases also the lesion load in Alzheimer's disease. So it seems that a good flow and a good velocity of a CSF should be an important piece of the puzzle. The second point, the second G, is hypoperfusion. Brain hypoperfusion in multiple sclerosis is a fact. But hypoperfusion certainly is not related to autoimmunity, but an answer to hypoperfusion. in pathogenesis is very important. This is a fantastic study on brain where the relapsing remitting people were followed up by the means of MRI every 2 weeks. And this showed clearly that hypoperfusion precedes plaque formation. You may see that there is hypoperfusion measured approximately 2 weeks before the appearance of a new lesion. The consequence of hypoperfusion in MS are a condition that has been defined by Bruce Trapp as virtual hypoxia and is behind chronic necrosis of demyelinated axons in MS. But also, there is a great susceptibility to oligodendrocyte to hypoperfusion. So the probability to remyelinate, to repair the lesion in MS is impaired in hypoperfusion condition because the oligodendrocyte synthesize less myelin. In fact, this is a study performed in Harvard by fusion imaging technology of MRI and SPECT, and show that plaques are localized exactly in the brain region exhibiting hypoperfusion, but also in regions with good perfusion. The same group of investigators showed repair and remyelination. So it seems very important to maintain a good perfusion in the brain in order to increase reparation and regeneration due to MS. So the key question is, may cerebral perfusion be improved by increasing the venous outflow? Because everybody are focalized in arterial inflow when considering the perfusion of the brain. There are no studies investigating if perfusion can be also due to delay in venous drainage. This is a group of patients operated, and you may see the respectively the pre and post-op flow in the internal jugular veins and the rate of the collateral flow respect to vein flow. And you may see that we may obtain a very good increasing of the venous outflow through the main routes and a significant and dramatic reduction of the collateralization in the post-op. In the same group of patients, we measured the perfusion by the means of SPECT, and the first histogram show you the hypoperfusion respect normal controls in this group of patients. In 60 days post-op, you may see respect the same group of patients of controls, the significant reduction and improvement of the perfusion. Just the case to see, you may see the SPECT in this lady of 45 years old with the cold and blue color of hypoperfusion. Inflow, the brain outflow is written, and you may see that the collateralization dramatically reduced from 80% to 11%, and the flow through the jugular from 200 to 1000 milliliter per minute. And this corresponds to this map of perfusion, where you may see diffusely the warm color of better perfusion. So certainly, this is a big news. You may increase perfusion, especially in people without any kind of problem in vein flow, by acting, improving the outflow. Balloon angioplasty is open vein repair or maybe devoted stented needed? We think yes. This is the survivor analysis curve of our first group of patients published in 2009. You may see that there is more than 50% of failure of balloon angioplasty. And we revised these cases and found that PTA failure is due to the presence of long, not mobile, and asymmetric leaflet, because when you inflate the balloon, you lift up the leaflet and do not obtain any notable effect. Also, in case of compression, balloon angioplasty is completely useless. Is effective only when you have short, stack, and symmetric leaflet at the level of the junction. So also technique needs to be improved. This is a summary. Pathology landmarks clearly show a diseased vein wall in CSSVI. Thus, it is a vascular disease. Transit and clearance time through the IJV route is significantly prolonged in CSSVI patients. CSSVI is linked from a pathophysiology point of view to both hypoperfusion and reduced CSF dynamics. To fix flow in the IJV permit to improve both brain perfusion and CSF dynamics. The higher jugular flow and hypoperfusion of the brain may represent a selection criteria. I want to add that exactly the last week of this year, we finished a double-blinded controlled trial in Italy, experimenting safety and effectiveness of balloon angioplasty in this field. So we have 1 year to conclude the follow-up of the patients, and this will be concluded within 2015. So in early 2016, we may have more information thanks to this randomized controlled trial. So thank you for your attention.
Thank you for your interesting talk, Professor Zamboni. Is there any question in the audience? Yes, please.
My question, what do you think about adding more information? Patient live 30, 50 years with this chronic hyperfusion of brain, with big pressure in the venous system, with retrograde flow, with venothrombose, and patient without headache, without symptom, and live many, many years.
This is a very good question. I think that there is certainly a limit in this kind of procedure because, for example, in the randomized controlled trial that I mentioned, we limit in the inclusion criteria to people with less than 10 years from the with a disability score permitting us to measure the walking ability. So the first results will come next year in a very specific group of patients where maybe there could be some probability to have some recovery of function, or maybe to reduce the aggression of the disease thanks to better perfusion, or for the pathophysiology that I showed you. I think that in people with very long and chronic history, with remodeling of the brain with connective tissue and changes like this, it's very difficult things to have something to do.
Thank you.
Hi, I'm a patient actually of MS, and simply my question would be so direct like this: why is every neurologist I've spoken to against your procedure, or they're telling me, recommending me not to get that technique or try it even? Sorry.
I don't know, because maybe I am not the right person, so probably you have to ask to the neurologist. But what I would say is that we cannot stop the research activity. I do not treat patients in the hospital out of controlled trial, of controlled studies. So I am interested in research, and I think that research may offer an opportunity at the end of the travel, of the trip, of the research. What I think is not right is try to stop the researching course with ethical committee and IRB that approved the research. So this cannot be done. And before to express any judgment is a prejudgment. You have to wait for the end of the research.
Professor Zamboni, besides the controversial about the results, about the frequency of the venous insufficiency, of the not very good results in the short trials, how can you explain, looking at the multiple sclerosis patients, looking at the diversity of the clinical picture, you can see patients with very benign forms, only or 2 episodes alive, patients with the progressive, patients with almost exclusively lesions in the cervical spine. How can you explain with uniform pathophysiology this diversity in the clinical?
Of course, I don't know everything, but some important news between the correspondence in topography of lesion and symptoms and topography of the extracranial vein draining a specific area is very well described. What I found very interesting is that patients with primary progressive MS are patients with mainly paraparesis, spastic paraparesis, and mainly lesion confined in the spinal cord, with very few lesions in the brain. What I found is practically any possibility to have procedure is impossible, because this kind of patients, in my experience, show aplasia or hypoplasia of the extravertebral plexus. And this is the cause of a venous return along the spine without any possibility to reach the adagos system and the caval system through the extra spinal venous plexuses. I think that this is very important, because is a biomarker of why there is a primary progressive respect to relapsing remitting or a secondary progressive cause. I think that this is a very important thing, but unfortunately nobody performed lumbar and ascending lumbar and selective venograms, adigogram in primary progressive multiple sclerosis to have reproducibility of this data in other center. I think that this could be done. It's very interesting.
Well, this is an interesting observations, but one aspect of the disease that we see in the intracranial venous system is veno-occlusive disease, particularly following venous sinus thrombosis. And there is a group of patients who present with benign intracranial hypertension. Right? They have venous stenosis in the transverse sinus or sigmoid sinus. And there are reports that when you do a venoplasty in these areas, there is a dramatic improvement in the symptoms. It's the same hypothesis, basically. The only difference is that it is an intracranial occlusion as compared to what you propose, that there is an extracranial venous system which is getting affected. Now, there's another point of very important concern here, that, of course, there are a contradiction to the hypothesis that whether the venous stenosis in benign intracranial hypertension is a cause or the effect. Because every time that you do a venoplasty, it doesn't resolve the intracranial hypertension. That's one point. The second important point is that we do see in many restrictive diseases, or particularly again in relation to veno-occlusive disease. Again, spectrum commonly seen in the young middle age. The venous drainage system of the brain has an enormous, what we call adaptation to go through various routes. Commonly that we see in dural venous sinuses occlusion, that it adapts through the pterygoid plexus system and through the ophthalmic system, which acts as a buffer to adapt to the venous outlet. So if it is the mechanism that there is a occlusion of these extracranial venous systems, why those alternative adaptive mechanisms are not operating in multiple sclerosis?
Okay, the first question is cause of effect. It's a very good question. I will discuss with the first point, remembering pathology of the venous wall. The group in Geneva is a group of pathology, studied the jugular vein and did not find any type of T lymphocyte in the wall. So if this was an effect of a MS, you have to expect infiltration, autoimmune infiltration in the veins. And the pathologist told us that there is no infiltration. There is a change in type of collagen. Can be due to MS or to Parkinson or to Meniere? I don't think. And calcifications in the vasa vasorum, I cannot think that this is an effect. Maybe is another aspect of the disease, but it's not pathogenetically linked with autoimmune disease or immune system. The second is very interesting. We developed a transcranial Doppler approach to the condylar veins and showed that in case of optic neuritis, there is a greater chance to have here the petrosus sinus and in the cavernous sinus bidirectional flow. And usually this is monodirectional flow. Bidirectional flow means that there is a part that is drained through the orbit, the very obvious hole, and there is a lot of circulation through the pterygoid plexus. But also, according to, I have not time enough to show everything, but there is a beautiful paper in the American Journal of Radiology published last November, showing from a group of mathematics and physiologists, showed that in case of the double obstruction of the jugular vein, you may have this shunt from the arterial part of the brain to the meningeal through extra intracranial anastomosis, and this could be the cause of hypoperfusion. And this because the increased resistance in the venous system allow a shunt from the parenchymal arterioles to the meningeal arterioles. In fact, when we measure the return, there is a big discrepancy between the flow in the external carotid artery and the collateral flow. It's not coming all from the external carotid artery. So maybe could be shunt through extracranial anastomosis, and this may be the cause of the hypoperfusion.
Thank you. It's a very interesting discussion, but we need to finish. Thank you very much, Professor Zamboni. It's time to invite the next speaker.